Hello, my name is Joselyn Masapanta Ascension. I'm topic about coronary angiography after cardiac arrest without SD cementing elevation. Definition: ischemic heart disease is a major cause of hospital cardiac arrest. The role of immediate coronary angiography and percutaneous coronary intervention in the treatment of patients who have been usually rushed after cardiac arrest in the after of SD cementing elevation, myocardial infarctions, remains uncertain.
This animation is brought to you by Skillshare, an online learning community with thousands of inspiring classes for creative people. Explore new skills, deepen existing passions, and get lost in creativity. A coronary angioplasty procedure is also known as percutaneous coronary intervention. The procedure is done on blood vessels called coronary arteries. They supply your heart muscle with oxygen. The goal is to restore blood flow if a substance called plaque has significantly narrowed these vessels. To begin the procedure, the doctor will numb the skin in your groin. A needle will be placed through your skin and into the femoral artery. Next, a flexible guide wire will be passed through the needle into your artery. Then, the needle will be withdrawn. It will be exchanged for a small, flexible tube called a sheath. This permits access into your artery. You may feel pressure when the doctor inserts the sheath, but you will not feel it moving inside your artery. Next, the guide wire will be advanced up to your heart. A flexible tube, called a catheter, will be advanced over the wire to your coronary arteries. The progress of the procedure will be checked with an X-ray device called a fluoroscope. At this point, your doctor will remove the guide wire. Then, the doctor will move the tip of the catheter just inside the coronary artery to be examined. A special dye will be injected into the artery. This allows your doctor to view it better with the fluoroscope. The dye will make any blockages in the artery stand out. If a significant blockage is found, your doctor will insert a guide wire into the artery. A balloon on the tip of the catheter will be moved along the wire to the blockage. When the balloon inflates, it will expand the artery and improve the blood flow. You may feel some chest discomfort while this is happening. After this, your doctor will deflate and remove the balloon. A wire mesh tube, called a stent, may be placed in the treated area. The stent helps keep the coronary artery open. Your doctor will choose the proper size stent, which is compressed over a balloon. The stent will be moved into the artery over the same guide wire. When the balloon is inflated, the stent will expand and lock into place. After the balloon catheter is taken out, the stent will stay in place to hold the artery open. At the end of the procedure, the guide wire will be removed. To find out more about coronary artery angioplasty, talk to your healthcare provider.
Application in nursing. A study of immediate angiographic lag superior in terms of clinical results at 1 year when compared with a strategy of delayed angiographic in patients usually for resuscitation following of hospital cardiac arrest and without symptom of STEM.
Every year, thousands of people have cardiac catheterizations or angioplasties. That's when a doctor threads a catheter to your heart arteries to look for blockages and other issues. If they do see a blockage, they can decide if placing a stent to open it would be beneficial. For years, doctors have used the artery near your groin as an access point for this procedure. But now some are using the artery in your wrist. Why? Because it may be safer and easier on patients.
You like picking. I have the best picking you've ever heard.
Mountain music. Wood. To Greg Beamer, that combo can't be beat.
This stuff is fantastic.
When you watch Greg doing his thing in the shop, you never know that once a week or so, he gets hit by chest pain, stable angina.
I have chest pain, heaviness, pressure.
His symptoms are the result of a heart that's kept on beating despite heart attack, a bypass.
There's a certain part of my heart that isn't working.
And 6 stents to open narrowed arteries. Dr. Rajiv Gulati says most of those stents were placed the traditional way, via the femoral artery.
The downside of that has been that patients will often need to lie flat for a number of hours after the procedure because there's a risk of the femoral artery from bleeding because it's under high pressure. And we need to allow the vessel to heal up before we can have the patient to move around.
But Greg's last stent was placed using a different entry point, the radial artery in the wrist.
There have been a number of studies now that have compared femoral versus radial access, and every single study shows a lower bleeding risk.
Plus, there's often less discomfort, and patients can go home the same day and get back to normal activities. Now, here's how the two procedures compare. For the traditional method, doctors place the catheter into the femoral artery and run it up to the heart. For the other method, doctors start at the radial artery in the wrist and thread the catheter to the heart. Same access to arteries, but fewer risks. Greg says if he ever has to have another stent, he's going to opt for the wrist procedure.
I know the difference.
Right now, Greg's not thinking about what might happen in the future. He's focused on working with wood. In his shop,
You want to hear acoustical picking? Listen to this.
to the tunes of mountain music.
How can you get unhappy with something like that going on?
Dr. Gulati says if you need a stent, there's no guarantee you can have the radial artery procedure. Only people who have good blood supply to their wrist and arteries that aren't too small are candidates. Also, some people who have bypasses can't have the procedure because wrist arteries are sometimes used in that operation. But for the right person, this procedure can be very beneficial. For Medical Edge, I'm Vivian Williams.
Pros and cons. Pros. Randomized control multi-center trial NTT analysis sensitivity analysis survival is a patient. Century outcome. Primary outcome measure of 19-day mortality is a robust endpoint. Cons. That recording patient age need often only and finally pairs of trialing small population analysis may not a result the analysis and of a large population.
I guess maybe the first interesting topic would be the angiogram and how well the angiogram works in finding the plaques that are going to cause trouble. I know you used it in your 2000 paper on complex lesions, and you got a lot of valuable information out of there. What do you think of its potential for vulnerable plaque detection?
the angiogram has been the workhorse of both diagnostic and now therapeutic interventional cardiology for over 50 years, and it has led us into the promised land of changing the way we treat patients with coronary disease. And for years, we focused on these critical narrowings, and we associated with flow-limiting stenoses, and pretty well the angiogram did a good job. If you saw a tight narrowing greater than 80%, you could be pretty confident it was limiting flow. And if it had features that were unstable, where it had filling defects and ulcers, you could be pretty confident it was an unstable plaque. If you saw an area of the vessel that looked normal or had a less than 30, 40, 50% narrowing, you could be pretty confident that the vessel wasn't very significantly diseased and that the narrowing you saw wasn't limiting flow. But over the past 10 years, we've begun to understand that the angiogram has great limitations. So on either end of the spectrum, when there's no or minimal disease, we don't worry about flow limitation. When it's severe, we pretty much know what to do in terms of treatment. But in the wide in between, there's a lot that the angiogram doesn't provide, both with respect to two fundamental issues of how we treat patients. One is, how do we do a better job in the cath lab in patients in whom we're going to intervene, and how do we do a better job at making sure that we treat the right lesions, treat all the right lesions that are going to benefit the patient, and then get the best outcome in the cath lab and subsequently from our treatments with stents. And then the larger question, what do we do in terms of finding those plaques that you have helped us understand are vulnerable, that look unimpressive by the angiogram, that are not narrowed in particular, that are not flow limiting, that may serve as potential for a future heart attack or sudden death. And so we need to move beyond angiography alone, because angiography alone is not enough to achieve optimal outcomes for percutaneous coronary interventions, and angiography alone is not sufficient to detect those plaques that are going to be problematic in the future and cause these potentially calamitous events of heart attack and sudden death. Well, let's go back to the fundamental question about, is angiography sufficient? And what angiography misses is it grossly underestimates the presence of atherosclerosis, it grossly underestimates the magnitude or extent of atherosclerosis, and tells you very little about the composition of the plaque.
Use apply in Ecuador. The mean age of presentation is 5 years. The most frequently effect was made up in 1836. A basic coronary angioplasty was performed in 1902 persons. The most frequently treated artery was the left anterior descending finite, when the technique most frequently accessed was the coronary artery, and 70 patients.
Ischemic heart disease is a major cause of out-of-hospital cardiac arrest. In patients with cardiac arrest who do not have ST segment elevation or ECG, the role of immediate coronary angiography and percutaneous coronary intervention after successful resuscitation is unclear. In this multi-center randomized open-label trial, 552 patients who were successfully resuscitated from out-of-hospital cardiac arrest and who did not have ST segment elevation on ECG were randomized to an immediate invasive strategy with angiography and revascularization, if appropriate, performed within 2 hours, or to a delayed invasive strategy with angiography and revascularization, if appropriate, performed after neurologic recovery. 14 patients were excluded after refusing retrospective informed consent. The primary outcome was survival at 90 days. A key secondary outcome was 90-day survival with a cerebral performance category score of 1 or 2, indicating good cerebral performance or no more than moderate cognitive disability. There was no significant difference between the intervention groups in the primary outcome.
There was also no significant difference in the key secondary outcome of 90-day survival with a cerebral performance category score of 1 or 2. The authors conclude that in patients successfully resuscitated from out-of-hospital cardiac arrest without signs of ST segment elevation myocardial infarction, an immediate invasive strategy does not improve survival at 90 days as compared with a delayed invasive strategy. Full trial results are available at nejm.org.
Conclusion. In medium angiographic following shows amongst patients without of hospital cardiac arrest week, and initially show remain an absence of ST17 elevation on XCD is not where they are struggling of daily angiographic with respect to overlay support at 19 days. Thank you very much.